Firstly, about assessment of LV function, ejection fraction and longitudinal strain. Now, the EchoNet RCT was designed to test whether AI-generated assessment of cardiac function was at least as good as that of a sonographer. So all these echoes were divided into two groups. In one arm, those who were actually assessed by the sonographer, and the other arm, which had AI assessment. And the results were blinded to an experienced cardiologist who didn't know which arm the report belonged. And it was found that the cardiologist agreed more often with the AI-generated data rather than the sonographer interpretation. And actually, statistically, it was shown that AI-generated data was superior to that of a sonographer. If you look at the FAST-EF multi-center study, it showed that AI-generated measures of LV function like EF and longitudinal strain were reproducible and could be done very rapidly. Coming to LV volume measurement, well, again, machine learning helped you to obtain the dynamic quantities of LV volumes more quickly and more accurately. And similar thing was true for LV mass measurement. Now, what about assessment of wall motion abnormalities? Now, it showed that the AI could prove improved detection of regional wall motion abnormalities, which was better than the human eye could perform. And another study showed that for detection of wall motion abnormality, AI has a sensitivity, specificity, and accuracy of 96%. And if you incorporate AI in its stress echo, then you can better categorize a group of patients who are at low risk of imminent cardiac event. What about assessment of LV diastolic function? Now, in patients with suspected elevated LV EDP, echocardiography, AI was able to identify correctly about 80% of patients with pulmonary capillary wedge pressure more than 18, even from a 2D cardiac ultrasound image. And it was also seen that from a single apical 4-chamber transthoracic echocardiographic video clip, AI is able to discriminate patients very well, those with heart failure with preserved ejection fraction and those without heart failure with preserved ejection fraction. And if you compare the conventional scores that are used to diagnose patients with heart failure with preserved ejection fraction, AI did better in the sense that they are able to narrow down those those patients who would otherwise be non-diagnostic with the heart failure scores. Now, coming to assessment of valve disease. Now, we have learned about mitral valve regurgitation, MR, for example, but how many of you do you really get time in a busy lab to do all these things? Now, most labs, they don't. Forget about probably a few labs which are really good and doing it all the time, but most labs, they do not. They do not have the time, and probably they may not be that trained as well. So this sums to say, for example, measurement of PISA. It's time consuming. How many do it manually? But with AI, you can generate all the data in few seconds. So it's really helpful. Not only that, look at the valve morphology. There are other things that you probably may need. What about the mitral valve area? What about the coaptation length, coaptation depth that we talked about? All these things can be provided with AI. And similarly, AI can, in patients who are going for TAVI, AI can give us a measure of the aortic annulus, the size of the aortic root, and may help us to choose the TAVR prosthetic size. Now, coming to RV volume and function, yes, AI can also give an accurate quantification of RV volume and function. It may also help in differentiating among disease entities, such as to differentiate from constrictive pericarditis and restrictive cardiomyopathy, to differentiate hypertrophic cardiomyopathy from athlete heart, and also in patients with left ventricular hypertrophy, it can help to suggest the diagnosis, whether it's hypertrophic cardiomyopathy, amyloid, or maybe hypertension, which has caused the left ventricular hypertrophy. So far as intracardiac mass is concerned, AI uses image texture analysis to differentiate between cardiac tumors and cardiac thrombi. And in patients with cardiac tumors, they also suggest the differential diagnosis. Now, image acquisition, we know it's very important. And how does AI help? It may help the novices by teaching them how to do a good echocardiography and can get good pictures. And this is the way they can do it. They can actually prompt the sonographer regarding the use of the probe, the angle that the probe has to be moved. And also, if there's a good image is obtained, they would probably capture it spontaneously. Now, it also leads to a change in workflow. And how is it done? Like, as you know, what we do now is the sonographer actually acquires the images, and then the interpreter, which is usually a cardiologist, would go through this non-consecutive images, that's 2D, Doppler, and then come to a conclusion or a diagnosis. With AI, you can actually group the relevant images together. For example, if there is a LV valve motion assessment query, that would display all the cine images of the LV serially, and it becomes so easy to actually make a diagnosis. Similarly, a query for aortic valve stenosis would display the 2D and the 3D or the LVOT images, the Doppler images all together, helping you to come to the diagnosis. Now, prognostication, yes, it's been seen like AI can help prognostication by predicting all-cause mortality by combining echocardiographic data with the medical information. Now, despite all its good points, there are certain limitations and challenges that we have today. Now, deep learning uses a black box model, and that is something which is very poorly understood even by the experts. So naturally, there is some hesitancy in its uptake by physicians. Next, there is large amount of well-annotated echocardiographic images that's necessary to train the machine. But we may not have all this data. Now again, when we train these machines with this data, these are mostly real-world data, and they have to be labeled. And then there may be a potential bias in the labeling process. Still now, there is paucity of studies with robust clinical outcomes. And then the suboptimal image quality during acquisition can also be a problem for AI to interfere and interpret. Presence of arrhythmias could be a challenge. Another thing we have to keep in mind is there may be racial differences in the physiology and anatomy of the heart. So an AI model which has been validated in a particular race may not be applicable to another. So this is something, so we actually need AI data for different geographical locations or different race. Of course, there are legal and ethical issues. If something goes wrong, who is to be blamed? AI or you? Who takes the responsibility? And the ethical issues, because we are dealing with a large amount of data, which are, what if there is a security breach and there is leakage of this data? So these things have to be sorted in future. So in conclusion, and I'm much before time, AI could help to train echocardiographers, improve image acquisition, and analyze and interpret scans, change the workflow pattern in the echo lab. It may help to improve diagnostics by measuring LV and RV function, LV mass, quantified chamber, help in assessment of diastolic function and valvular abnormalities, and help in differentiating disease entities. Deep learning could improve prognostication. AI-derived data is generally reliable and reproducible. AI could save time, improve productivity and workflow, and de-stress the operator. AI is coming in a big way and is here to stay, whether you like it or not. But the good news is it's unlikely to replace the physicians, but will complement them. So what lies in the future? I never think of the future. It comes soon enough, said Albert Einstein. And I can't agree more with him. because only this month there was a report that a robot committed suicide in Korea because of excessive workload. He jumped from the stair, and some unusual behaviors were witnessed before he did so. So maybe in future, we should start thinking not about how to distress our sonographers, but perhaps how to distress our echocardiography machines. Thank you.